So for our case today, we are going to be talking about a case from the cardiology service, a person who is still currently admitted. And because there are, not a ton of people logged on, please either speak up if you have questions or have anything to say, or put your answers into the chat. Otherwise, this is going to be a ton of me talking, which is going to be uncomfortable for everyone. So let us get started here. So you are called by the ED to admit a patient because they have hypertension. So your patient's vitals, 36.5, so afebrile. Their heart rate is 96. Their blood pressure is an astounding 259 over 156, giving them a MAP of 184. And they are satting 98% on room air. So clearly the striking abnormality in this set of vitals is that this person is remarkably hypertensive. And so what I want you guys to do is take 30 seconds and put into the chat what focused questions you're going to ask this person and sort of what's going through your mind as you walk down to the ED to evaluate them for the first time. And please throw those answers into the chat. Essentially, what information do you want to get from this patient to help you further work them up? Awesome. So Hoda says chest pain, headache, blurred vision, urination. Card saying the same stuff. Megan, same stuff. Headache, vision changes, nausea, vomiting, chest pain, shortness of breath. Awesome. So you guys are all on the right path. So trying to figure out whether there's a cardiac component, a neurologic component, an ophthalmologic component, etc. All right. So let us get a little bit more history here. All right. So here's this person's history, and I'm going to go ahead and read parts of this for you. So their chief complaint is right-sided weakness and a pounding heart. And on the HPI, it's a 51-year-old male who has a history of a hemorrhagic CVA in 2017. He's got some left-sided hemiplegia from that. Hypertension, coronary artery disease with one stent to his LAD in 2013. He's coming in with right-sided weakness and elevated blood pressure. Notable other history findings, I'll say that Sarah Slavin, one of our residents, took an excellent history on this. He's got malaise and lethargy for the past couple weeks, nausea, fatigue for the past 2 days. But the morning of presentation, he felt he had pounding in his chest, new right-sided weakness, dyspnea on exertion, orthopnea, and PND. The PND, orthopnea, and dyspnea were going on for 2 weeks. His review of systems is notably negative for the following things, which you guys asked about in your initial questions. Headache, dysarthria, aphasia, chest tightness, etc. Past history, similar to what we talked about earlier, he does have a history of hypertension. His medications, he's only on aspirin, atorvastatin, carvedilol, and nifedipine. The nifedipine is a daily medication. He smoked a bunch of cigarettes for a very long time, but is now just down to 5 to 6 per day. No alcohol, and his functional baseline is bedbound, but he is able to transfer to his wheelchair. Any thoughts from people in the chat about this sort of history? Anything jumping out to you? Anything that makes you more or less concerned about this patient? Awesome. So Hoda's saying she's concerned about secondary causes of hypertension. The cards team is immediately going to the fact that he's got this sort of right-sided weakness. Sneha's concerned about his age. I think those are great. And so the way I kind of want to set up this conference is from this point on, I'll let you guys kind of dictate what we're going to see next, whether it'll be exam, vitals, labs, etc. So in the chat or out loud, does anyone have a preference on what they would like to see next? As a reminder, we know that this person is hypertensive, and we know that they're coming in with these symptoms. Where do you guys want to take this case? Awesome. So Hoda is immediately saying she wants that EKG, the trope, and the CT of the brain. Awesome. So let's do that. So let's go ahead and we will jump right into this gentleman's labs. All right. So for your labs, you're going to get a CBC, obviously. You're going to get your BMP. I'm also going to give you LFTs. Hoda is asking for a trope and a BNP. She also wants that EKG. And then Sneha says she's agreed with the CT non-con. Awesome. Okay. So Hoda, just because you're currently participating, which is great, what are you expecting to see on this BMP?
Mainly I want to look at his renal function. Electrolytes, but again, I'm looking at end organ damage. And also if, again, thinking about secondary causes, if there is any renal component to this, which sounds like there is.
Great. Yeah, so absolutely. So his renal function coming in right now, his creatinine is 7.8 with a baseline of 2.9, so significantly elevated. Glucose is normal. And then on his CBC, his white count is 15.0. His hemoglobin is 10.5 from a baseline of approximately 15 with a platelet count of 225. I'll tell you that his LFTs also fairly normal overall, with an AST of 11, ALT of 5, and an ALK Phos of 91. And so Hoda, just because you were so gracious to participate, what else jumps out to you on the labs right now besides that renal function?
Sorry, I got distracted with discharge orders. Oh, he has a white count for sure. He's anemic. What else? LFTs overall look okay. I think those are it for me.
Perfect.
Podium, Hoda.
Perfect. And then I'm also gonna, I think obviously I'm not gonna hide the trope and being free from you here. So we have a high sensitivity trope at the U now. So the future has come to the university, and the high sensitivity troponin is 175, and on recheck goes to 252. And so for our cardiology team, because I actually went upstairs and asked them this the other day, how do you guys utilize the high sensitivity troponin? Because I can now officially say that back in my day, we did not have this. Awesome. So Cards is saying the delta change greater than 20 is more concerning for ACS. That's perfect. So I'll give you that this guy's delta change here was 44%. So concerning for ACS, and his BMP, I don't have the exact number, but it was elevated as well. Just because we're on the labs right now, are there any additional labs that you guys would want to grab, knowing that this person's coming in with hypertensive emergency and these existing labs? Awesome. So Cards is saying that they would also like a UA, a UTOX. Perfect. So while people put some more stuff in the chat, I'll give you these numbers here. So his UA, he's got greater than 500 protein, and he's got quite a bit of blood. So greater than 75 RBCs with large blood. This is new compared to his prior. And then his UTOX, I will say, is negative with the exception of cannabinoids. So overall negative for a person that lives in Colorado. And then the cardiology service is also asking for an LDH haptoglobin for his anemia and a peripheral smear. And if someone in the cardiology room can talk on the audio and let me know sort of why they want to grab those things, that would be fantastic. Getting some radio silence from Card, which is okay. So I'll tell you his values here. So his hemolysis labs, his LDH is elevated at 460. His haptoglobin, which I'll just call hapto here, is less than 30, which is what we sort of becomes undetectable at UCH. And his peripheral smear has 1+ schistose and some small red cells. So for any of the people who are logged onto this conference, what do you guys make of these hemolysis labs? Awesome. So Megan says it sounds hemolysis-ish, which is good. I like that. I'm not sure if that's a word, but I approve. And then Sneha mentions that it's weird though, right? Because his bili is, not really that elevated. Cool. Okay. Any additional labs that you guys want right now, or do we want to sort of move on to some more objective info?
Maybe later. I don't want to do it now because this is more emergent, but sometime like aldosterone-renin ratio.
Great.
Yeah.
I like that. And Hoda, why are you interested in that?
Like hyperaldosteronism.
Awesome. So sort of getting back to what you said right away, is there sort of a secondary cause of hypertension at play here? I think that's awesome. All right, Megan is saying it, so we're gonna do it. She wants to get that EKG. So here's this gentleman's EKG, and I will give you all about 30 seconds to take a look at this. And then Megan, because you asked for the EKG, I'm gonna ask you for your focused read in about 30 seconds.
I'll just get going here.
Yep.
For the rate, it looks like a little less than 100, just doing the 300 divided by the number of boxes. For the rhythm, it looks pretty regular. I think the thing that kind of draws my eye is that it looks like maybe some ST depressions in 2, but then you kind of get these weird morphologies in the precordial leads where I think that might be an elevation. But then you have these like flipped P waves and T waves. I mean, it's definitely concerning. I don't feel like I have the, ST elevations in 2 leads with reciprocal depressions, but there's enough abnormality that I'd be worried with the story.
Great. That was a great read. I completely agree. And so for that component of it, a cardiologist took a look at this and said that these depressions right here were concerning for subendocardial ischemia. And so they did not think this met classic criteria for STEMI, but there was some subendocardial ischemia. And then Megan, what else do you notice about the QRS complexes in this?
There's some, this is not formal, but there's definitely some morphology. Is that like a S or SMEEK? Yeah, sort of a weird morphology at the end of the S, specifically in 3 and AVF.
Great. So you're saying, so there's kind of this weird morphology right here. Perfect. And then that's great. And then for someone else who is logged on, because I don't want to push Megan too far here. What do you guys generally make of like all of this in the top right corner? Yeah, so card says positive running off the page sign, which is great. And so for the cards people in the chat, what does that make you think of? Great, so LVH. So Megan hit sort of the most concerning part, which is the thing you can't miss, which is ruling out in or out whether there's any sort of ischemia or cardiac issue. And then cards sort of hit on that more academic point that there may be some LVH here. And then the other interesting finding from this EKG is you've got in 2, you can see this kind of peaked P wave. And then if you look in V1, you can see it dropping down right there. And so 2 is typically where we look to see for right atrial enlargement or RAE. And V1 is where we look to see if there's left atrial enlargement. And so in addition to Megan's excellent read, this person also has LVH with BAE or biatrial enlargement. So right now, this kind of fits, I think, with the pattern of hypertension, the severity of their initial presentation. And now, as Megan correctly pointed out, we are concerned that this person has some subendocardial ischemia. Great. And Megan's saying that is there amyloid as well, which is a great thought anytime you're seeing LVH and sort of conduction abnormalities or sarcoid. Megan, both of those can cause LVH, infiltrative disease, and conduction abnormalities. Okay, so I think Sneha is going to file a formal complaint against me if I don't talk about this gentleman's physical exam. So his physical exam, which again was
Danny, here's the thing. I have never checked for papilledema because I don't know how, and it's can't really get that close to someone's face without laughing. But Dr. Linus always tells us. So I thought I would tell you all.
Oh no, I completely agree. If between the 15 of us that are on this call, I also have never checked for papilledema because I am not an ophthalmologist and I cannot dilate anyone's eyes, which makes it very difficult to accomplish that. But I will say that on physical exam, this gentleman overall was fairly well appearing. He did not have papilledema. We'll say in hindsight, we know that he did not have papilledema. He did not have an elevated JVP. He did not have edema, and he did not have any increased work of breathing. And so overall, his exam was sort of, fairly normal given everything else that was going on. All right. So just to zoom out here and sort of let you guys sort of see what we've done so far before we pick next steps. We've talked about his labs for a guy with hypertensive emergency. We've talked about an EKG that showed some subendocardial ischemia and LVH. And then we've talked about an exam that was sort of well appearing overall. Where do you guys want to take this next? Options are imaging. There's a CT scan or a bunch of imaging studies. And then there is an echo. Cards is saying CT head. And Cards, why do you want a CT head on this person? So Megan says CT head and then blood pressure control. Great. So his CT head, I didn't pull this image, but his CT head has old microvascular changes, but no acute abnormalities. Anything else you guys want in the scanner right now, or do you want to go ahead and start treating this person? All right, let us go ahead and start treating this person then. So, talking treatment for hypertensive emergency. So you guys are going to be the ones responsible for putting these orders in. So, what medications do you want to order? How are you going to plan about going to treat this guy?
Use Nicardipine a lot.
Great. So Jonathan says he wants to put this person on Nicardipine. I love it. Nicardipine is almost never the wrong answer if a person has hypertensive emergency. And Jonathan, are you familiar with starting doses for Nicardipine? Any idea sort of what initial thing you would put into your order?
I think it starts at like 2.5. The units on that, I have no idea.
No, that's right. So the lowest you can go is 2.5. And so a typical starting dose is about 2.5 to 5 milligrams per hour. And so Nicardipine, as Jonathan brought up, almost always the correct option. It's a pretty safe medication. It causes a little bit of reflex tachycardia, but its onset of action is about 5 to 10 minutes. And then once you start it, it lasts anywhere from about 1 to 4 hours. And so some people sort of describe this as a quasi-titratable medicine because you can titrate it, but it does last a little bit once you start it. And so how frequently can you titrate it? Most people recommend titrating it about every 15 minutes or so, because that really lets your dose take effect. So you put in your order, you say, I want to start Nicardipine, I want to start them at 2.5 to 5. And sort of most importantly for the group here, what is our goal? Like, what are we trying to achieve by putting this patient on Nicardipine?
Do you mean like how much we want to lower him?
Yeah, exactly.
I'll say 25% in the first day. I think technically it's like in first 8 hours. 25% would be my goal.
Great. So Hoda says she wants to lower by 25%. And so just because, we're never exact in medicine, so 20 to 25% is sort of the appropriate amount you want to lower. Hoda said she wants to get him down that fast in the first 8 hours, which is, I like it. She put her nickel down. Does anyone else have a time frame for when they want?
No, I said 24 hours.
You said 20. Oh, you said 24 hours.
Yeah,
right.
24 hours.
So unfortunately, even less correct. But I like so does anyone else have a time frame for what they want this first 20 to 25%? When do we want to achieve that?
I think it's in the first a couple hours, but then you keep them there for a while, I think.
Great. So Jonathan says first hour. Megan says, isn't it 2 hours? Card says 1 hour. And so the official guidelines say that you want to drop by 20 to 25% within the first hour. And, I remember every time I admit a hypertensive emergency person, I'm always a little confused. Like, am I titrating this off of the systolic blood pressure? Am I titrating this off the diastolic blood pressure? Or am I titrating this off the map? And I'll say, just for, sort of the nursing ease, a lot of times it's easiest to titrate this off the map because it's a single number. And so this person's initial map, I believe, was somewhere in the 184 range. So his map was 184. And so if you want to drop this guy by 20, essentially 20% within the first hour, you want to get his map down to somewhere in that like 150-ish range. And so we do that right away with our IV medications or an IV push medication. All right, so you've dropped this guy by 20 to 25% in the first hour. What do we do next? I guess the way of asking this is, do we leave this gentleman at 150 with his right-sided deficits, or do we say that is still too high? So the next thing we want to do is we want to decrease them. Cards, yeah, so card says lower by 5 to 15% additionally in the next 24 hours. Great. So the next thing we want to do is we want to decrease them to about 160 over 100, which actually comes out to an additional 5 to 15% in most people. And we want this to happen over the next 2 to 6 hours. So we see them drop in the first hour, and we want to get them to 160 over 100 in 2 to 6 hours. And then the third thing is we want a normal blood pressure by essentially 48 hours. So these are actually the official guidelines from some renal and cardiology societies. And one of the interesting things, right, is there is a huge gray area in this sort of box right here. Between 6 and 48 hours, it basically comes down to provider preference and how you titrate your medicines, when you start your oral medications, et cetera. And so a lot of this is going to be attending dependent, with the ultimate goal of getting these people normal by 48 hours and down to 160 over 100 by 2 to 6. Any
Danny,
questions?
it's okay if you didn't look into this, but could you clarify like which population we're talking about, right? Because this is not the case if someone's having a dissection, but is this in a person that has no current comorbidities other than their renal injury? Can we do this in a person with an ischemic stroke versus a hemorrhagic stroke? Like, who should I be doing this in?
Yes, Sneha, that's great. You're like a plant. So what are our exceptions, like Sneha brought up, right? Because I think the confusing part is if someone falls outside of this very narrow box, then we have different goals. And so there are some big exceptions here. So people who are having a stroke, you want to defer to neuro. And the reason is there are some sort of different goals based on whether it's a hemorrhagic stroke, whether it's an ischemic stroke, what their pre-existing blood pressure is, what their goal is going to be. And so if they're having a stroke, let neuro guide this management and sort of wait for their note in your discussion with them before putting in these orders. The next thing that Sneha talked about is what if it's a dissection? And so that's another exception here. And so for a dissection, you want to decrease wall stress essentially as fast as possible. And so, almost within 20 minutes, which is what some of the societies say, you want to get their systolic less than 120, and you want to get their heart rate less than 60. And so dissection patients are often put on a medicine called esmolol, a rapidly titratable beta blocker, because esmolol makes it easiest to achieve both of those goals. And I'll say this is like within 20 minutes right here. And then finally, the other sort of last exception for this, because of course, is patients who are having ACS or sort of acute decompensated heart failure. I'll say in practice, I haven't seen this, but this review article and sort of some of the societies recommend dropping to less than 140 within an hour. But I will say this is going to be one of those ones where you're going to want to defer to the cardiologist and defer to the cath lab. Sneha, did that answer that question?
Yeah, thank you. I know hemorrhagic stroke is tricky. There have been a few trials without clear guidelines about whether to drop them below 160, 140, 120. It's tricky. So I agree. Defer to neuro on that one as well.
Yeah.
For ischemic strokes, a lot of times we allow that sort of permissive hypertension, right? But again, neuro can help you decide sort of what counts as that. Want to try to be less than 220 in certain conditions, like if you're going to consider TPA, et cetera. So.
Completely agree. And then I'm gonna see if Dr. Kearns is on here. I don't think he's still on the call. But the other question that often comes up is like, when do I start PO meds in these people? And most people, most societies, and I think Dr. Kearns and a lot of our ICU doctors' personal practice is once you hit this kind of 2 to 6 hour mark and that person is down to 160 over 100, that's when you start thinking about it. And certainly, you know, within the first 12 to 24 hours, you want to try to get these people on at least home meds or on a new PO med to get them off the drip as fast as possible. All right. So we have talked about treatment. We've got this person on a Nicardipine drip. You're titrating it. You've got your goals. So what do you guys want to do next? We've got some imaging studies left. We can look at an echo. Defer to you all. All right. Just because I pulled Card says TT sounds good. I was going to say just because I pulled it means that we should probably look at it, or else all my work was for nothing. So Cards, what view do you want first on your echo of the 4 views? I will take your silence to mean that you want a parasternal long. So parasternal long it is. So here's this gentleman's parasternal long. And then in the chat, just to crowdsource this one, what are you guys noticing on this parasternal long? Okay, so Megan says that the mitral valve right here is not slapping the septum. So the sort of this sort of indirect marker of squeeze, which is the EPSS, so the endpoint septal separation, right there is not slapping the septum. Sneha says the septum is markedly thickened, which it absolutely is. Great, so Megan's getting at that this guy looks like he has a decreased EF, and then Sneha's saying that this really correlates pretty well with the LVH that we saw on our initial EKG. All right, so next view, if we're going in order here, we're gonna hit him with the parasternal short. So you've rotated your, you've rotated, hold on a second. People knocking at the door. So you've rotated your angle here, and again, just to show what Sneha is pointing at, that that LV is still really, really thickened. And then sort of most notably, let's go ahead and do, just for the sake of completeness, his apical 4 chamber. And what do you guys notice on the apical 4 chamber? Great, so I think Megan is talking about this one, but she's saying again, very thickened LV. And then if you guys were gonna eyeball the ejection fraction on this, because we know there's pretty good data for non-cardiologists saying grossly normal versus grossly abnormal, would you guess the EF here was grossly normal or grossly abnormal? Yeah, so Megan is saying this is abnormal, which is great. And so Megan is exactly correct. And so ultimately this guy's EF turned out to be about 40%, but he had no other clear valvular abnormalities. He just had, as you can sort of see on here, global hypokinesis of that LV. And there was no prior echo, so this was presumed to sort of be a new diagnosis, and whether it was acute or subacute or chronic, it was unclear. All right. So there is a CT scan of his lungs just to show sort of an additional finding, but I won't bother you guys with that one. And so at this point, our working diagnosis, right, is that this person has hypertensive emergency. And in the chat, I want you guys to throw in what complications he has from his hypertensive emergency. How many different hashtags are you going to put on his problem list? And as a reminder, I will scroll back up here for just a second to this gentleman's labs while you guys think about what you're going to put on his hashtag problem list. So these are his labs earlier. Great. Cards hit me with a bunch of them at the same time. Perfect. So Cards is saying that this gentleman has hashtag and AKI. He's got some proteinuria, which we can throw in there. He's got hematuria as well. He has a non-MI troponin elevation, NMTE. Great. And then I think that's actually pretty good. We can also throw on there, because I think this was in the initial note, the question of does he have acute decompensated heart failure based on that initial bedside echo. And then from his initial stuff, you guys also mentioned, or Cards mentioned initially, he also has an anemia, and it looks very hemolysis-ish, according to Megan, which is a good term. All right. So that's perfect. And so hypertensive emergency, you're treating him. He's got kidney dysfunction. He has cardiac dysfunction, and he's got blood dysfunction. So this is our board right now. How do we tie all of those things together? And obviously the answer here is going to be hypertensive emergency. But just because hypertensive emergency, I think, is one of those things that we see a bunch, let's really briefly just talk about the various things that can go wrong. I know what you guys are thinking in your head. You're thinking, did Danny create that figure, including the brain, and draw the eyes on it? And the answer is yes. That is why I get paid the huge sum of money that I do to create semi-meaningless clip art in apps. Okay, so if we're thinking head to toe, Jake saying that picture is horrifying. Agreed, Jake. So if we're thinking head to toe in terms of what hypertensive emergency can cause, the biggest ones that you guys hit on are neuro, his right-sided weakness, cardiac, etc. So in the brain, we can see CVA. We can see intracerebral hemorrhage, which is why you guys all wanted that CT scan to start. And we can see a diagnosis called PRESS, or posterior reversible encephalopathy syndrome. And essentially what PRESS is you get sort of effect of that posterior occipital lobe, and presents with altered mental status, super high blood pressures. People who are on calcineurin inhibitors, so our transplant patients, are a little bit more susceptible to this. And so it's a good diagnosis to have in your back pocket. Moving down, the next thing we get to is sort of the great vessels in the heart, specifically the aorta. And so with hypertensive emergency, you can see dissection. And then once you actually get into the heart itself, like you guys talked about, you can see ACS and acute decompensated heart failure, all from that extremely high pressure. Within the lungs, as a complication of acute decompensated heart failure or that back pressure, you can often see pulmonary edema, which this gentleman had a little bit of evidence of on a CT. And then as you keep moving further down, you get into the kidneys, which is sort of the most concerning part for this gentleman, and you can see AKI as well. And so I think one of the interesting things here is how do we tie together this gentleman's anemia with his hypertensive emergency? And so does anyone in the chat, besides the cardiology team, because they know this patient, does anyone in the chat know how to tie together this gentleman's anemia and his hypertension? Great, so Jake is saying a TMA. And so Jake, if you are able, can you explain that a little bit more?
Essentially, my understanding is that when you have these patients with hypertensive emergency, one of the complications can be essentially this hemolytic picture that you see. It's like essentially a Maha type picture where you get like turbulent flow in the kidneys that creates this thrombotic microangiopathy. And so it can, the cause can be the hypertensive emergency itself, but it can also worsen the hypertensive emergency as well due to kidney dysfunction, is my understanding at least.
You have a pretty good understanding of that. Yeah, that was perfect. And so one of the sort of lesser talked about complications of hypertensive emergency, like Jake just mentioned, is a thrombotic microangiopathy, or a MAHA, so microangiopathic hemolytic anemia. And it's just like Jake said, it's turbulent flow, it's shearing forces, and it can either be a cause or an effect. But in this gentleman's case, hematology was consulted and thought that this was a direct effect of his hypertensive emergency. And so, you guys hit on this right away, but the team, when he got admitted, ordered a peripheral smear, ordered that haptoglobin, and then got an LDH. All things which I think were really, really nice, because I'm not sure I would have thought of that right off the bat. Any additional questions about complications of hypertensive emergency? Cool. And I think the thing that you guys did that was really nice is when you're sort of trying to figure out like a head to toe way to break this down, right? You've got your CT head to look for the neuro findings. This gentleman had a CTA of his chest to look for dissection. Pulmonary edema, you can hit that with a chest x-ray, or you've got it on the CT head. Acute decompensated heart failure, ACS, that's your bedside echo and your troponin. AKI, that's your BMP. And then this gentleman also got a renal ultrasound as well, which showed medical renal disease. And so unclear, there's definitely an acute component, but probably also a more chronic component. And then TMA, you're looking for any evidence of this on your CBC. And so that's sort of a head to toe way to hit all of your complications as you're working up someone with hypertensive emergency. All right.
Danny, can you talk about why nicardipine is preferred over nitroprusside or nitroglycerin?
Yeah, absolutely. So Sneha is asking why nicardipine over nitroprusside or nitroglycerin. So I will say Dr. Linus is a huge proponent of nitroprusside. And I think Dr. Linus's exact quote, who's one of our Denver Health nephrologists, is, "I hope nitroglycerin goes away forever," or something like that. Nitroglycerin should die a death or slow death. So nitroglycerin takes a little bit longer to have effect and is a medicine that's a little bit harder to titrate. But then the question is, why not nitroprusside? And does anyone know in this gentleman why nitroprusside might not be indicated, or might be maybe our second agent? Yeah, so Card's is saying, so kidney dysfunction. Yeah, so nitroprusside is renally, nitroprusside's big side effect is cyanide toxicity, specifically thiocyanate, which is one of the breakdown products. And it's renally clear. So in renal dysfunction, you can get buildup of cyanide, which is clearly not indicated. That being said, the nephrologist will tell you that if you want to use nitroprusside, you can usually check BMPs and check lactates, and it's a fairly safe medication as long as the person's not going to be on it. Usually, I think for greater than 48 hours or so, which is about the time when the metabolite starts to build up. And you can always stop it. I think you can dialyze off the toxin as well. So that's one of the things that's a little bit tougher. And then the other thing about nitroprusside is that I think it's a little bit harder to titrate. Unlike nicardipine, it doesn't have as consistent an effect. And so some people will need a ton of nitroprusside, some won't need it very much. But it's a good medicine, and you will use it in certain situations. But it's not one that I would reach for right off the bat for most people, just because of the cyanide toxicity. And nicardipine is a little bit easier to anticipate how it's going to affect the body. And then Sneha is also saying that nitroglycerin is a venodilator. And so, yeah, she's exactly correct. So nitroglycerin, you need to have arterial vasodilation, which is a thing that nitroprusside does. Sneha, do you have anything else to add on that topic?
No, I don't. I just remember that for quite a while there, the Denver Health ED kept sending me people on nitroglycerin drips, and it was just really difficult because they would be on like 500 an hour and just be having massive headaches, and it's not worth it to just dilate their venous system and cause pooling on the right side, but rather you also want to dilate their arteries. And so I kept switching everybody to nicardipine, and so just remember to choose nicardipine. It's a safe agent and really our go-to management here.
Yeah, completely agree. I think that's a great way to put it. All right, so if the cards team is still on, Amr, who brought the case to me yesterday, I was going to let Amr just give like a 1-minute update on how this gentleman is doing, and that's it.
Hey, can you guys hear me?
Yep, I can hear you. Go ahead.
Okay, sounds good. So overnight, so we got the guy off of the nicardipine drip. His pressures were doing pretty well. And then overnight, his blood pressure is shot up again to like 200 systolic. And we're not really sure why he's becoming hypertensive again. Currently working up an etiology, like a secondary hypertension etiology, getting like epinephrines and renin to aldosterone ratio. And he's currently going over to dialysis right now.
Awesome. Amr, thanks. That's perfect. And so I think that just really hits on exactly what Hoda said, right? Was she was thinking about secondary hypertension really early on, even as early as when she first sort of got that initial history. And so unfortunately, in this gentleman's case, he might need dialysis, which is obviously not the preferred outcome, but I think still a really good case that points out, how common hypertensive emergency is, some of the big side effects, what we see on EKGs, labs, et cetera, and how we sort of focus our workup and focus our treatment once these people get admitted. And that's it. Thank you to Amr for submitting this case. Really, really enjoyed looking it up, and have a great day, everyone. And we will see you on the town hall tonight.